So delivering existing training in new ways, and the focus we were given was on mid-level managers. So the project title for us, we came up with Performance Learning Process for Mid-Level Managers and Increasing Capacity. So the concept we had was to create a process with the goal of continuous improvement of workforce performance and utilization of financial resources through blended, problem-based, individual, team, and peer learning. So I hope you got that. But it's basically continuous learning and using new methodologies, both for individual and team learning. Some of the assumptions, I don't think we have this later, but we made assumptions around the fact that the people that would be benefiting from this process would have already had some pre-service training, so they're not coming in naive. Second assumption was there are some existing structures for management and supervision that exist and structures for team-based learning. So for example, a health facility meeting or a monthly district meeting, that there's something already in place structurally that we would build upon. And third, that there is government buy-in and that this is really a government-led process. From a scale perspective, since this would be new, we decided to look at a subnational pilot, and geographically, we wanted to do someplace that was relatively easy, so similar cultural, language, etc., not difficult to access, and someplace that had been doing relatively well on a subnational basis, with the idea that the evaluation of this, we do some implementation learning research and look at what worked, what didn't work, and then hopefully go to national scale. The model, first, step one, which is step 0 here, our subject matter expert provided us with the concept of the learning audit. So looking at what's going well, what people are doing, what they have expertise in, how they're learning, some of the innovations to help really guide some of the rest of the work that would come. And we talked about temporally, would this happen once? Would this happen every 5 years? This would be a pilot, so maybe like 3 years. It would happen at the beginning, but we would have to decide at scale what would it look like. So from an individual perspective, we were talking about moving away from the residential didactic model for mid-level managers and going to a self-paced method of teaching, and that would be technologically dependent on the situation, maybe electronic, maybe workbook, maybe internet-based, maybe not internet-based, depending on the local circumstances. The second part would be team learning. So it would build on existing meetings, like we discussed, monthly district or health facility meetings, where you would undergo a kind of PDSA type. It's not quality improvement per se, but PDSA type methodology, where you look at your performance and what was achieved and have learning based on those particular elements that were highlighted as barriers, problems, challenges, weak areas of performance. The third part, which is linked to the team learning, is the team plus supervisor. So the supervisor would help, institutionalize this process at the beginning and also help provide specific topics, entry point for any updates and new information. And the last part of this would be some peer learning. So either kind of a learning collaborative type model where facilities or districts within a catchment area would learn from each other, or having learning visits. And we talked about building in the incentives in terms of recognition, like certification after completion of learning events, so moving away from what we talked about, that monetary incentive. In terms of learning methodology, we talked about inherently it's based on adult learning theory. It would be self-paced, staggered, problem-based, learner-controlled, and learner-centric. The caveat we had, again, is to account for a variety of conditions and infrastructure. In terms of the methodology, the overall objectives are to improve and sustain a competent workforce and institutionalize a continuous learning process. Dependencies, we were asked for buy-in, political commitment, finances, and the partners we discussed, both of the traditional MNCH primary healthcare and HRH partners. But we also looked outside of that to look at other sectors. Someone mentioned education, agric, and also looking at community leaders and community structures to get involved in terms of partnerships. Key activities would be identification of stakeholders, beneficiaries, and partners for the design part of this. We would have to identify the 3 M's, man, money, materials, or woman, money, materials. We would need to adapt the existing modules to accommodate this new methodology. The learning audit was in there, and then after the learning audit, actually do analysis to inform the strategy. When we would go into the geography sensitization and introduction of the new methodology and incentives and why people should be excited about this. Monitor implementation of the pilot and adapt based on implementation learning. Lastly, we had some discussions on gender. This is where we were kind of wrapping up, but the effect on gender being, gender roles, communication, and those type of things, and then disability, making sure that whatever learning methodology we have can incorporate some of those things, whether it's physical disabilities or learning disabilities, et cetera. And in terms of follow-up, we talked about evaluations for the individual learning, so module-specific or overall certification level, then ongoing supportive supervision to ensure the process is used and to support as needed, and lastly, a post-intervention evaluation. So, 6 months after the end of our pilot, are people still doing what we wanted them to do? And we're done.
With 30 seconds to spare. In which case, let's go back to the original sequence, and now we'll invite post-training follow-up, our red team.
Great. Good afternoon, everyone. So our group was in charge of to look at the post-training, how to make it more effective. So we were in our group. We did a lot of brainstorming. We had great idea. So we are going to give you a summary of our good discussion.
Okay, so we had one clear goal. So our idea is after the training, we really want to build a system that is going to be something that is going to build culture of sustainable and the culture of learning. So it means that we are going to be able just to have something that is going to help for the continuous learning. This is our goal. And then in terms of the concept, what we define is to design or to develop a multidimensional support system at the scale when we discussed with it. Oh, thank you.
So we discussed that we should target at some national level, so at district level, and then from there we had discussions about what should be the way to scale it up. So we decided that it's better to start with some targeted districts, and then from there to see what are the lessons learned, and based on the lessons learned, aim to expand it to the other districts. So it's kind of targeted, and then the idea is to go to only district level and to have a multi-dimensional support system. We defined what we aim to achieve in terms of direct impact and also indirect impact. So in terms of direct impact, it's quite clear that we want to improve the skills and the performance at 2 levels. At individual level, mainly the healthcare workers and supervisors, and then at organizational level in terms of the institution and of course of the service delivery. This is the first one. The second one, we really want to focus on improving the motivation, the staff motivation. The third one, we want to improve the way that we are being able to solve problem solving at local level. And finally, there is a data issue. So of course, we want to improve the data quality. So this is in terms of direct impact. And then in terms of an indirect one, we want to be able to strengthen the health system. We want to be able to deliver a better service, so quality service delivery. We want to increase the demand. We want, of course, to focus in introducing the cost saving, and also we want to focus in job retention with the idea that if we are able to increase the job satisfaction, then people are going to continue in their position, and then we're going to reduce the staff turnover. And at the end, we have kind of what we're aiming at the end is to have a better health, but this is really far away. If we look at the result change, this is at the end. And of course, we recognize that we are not going to be able just to assess what its contribution to our activities, but in somehow the contribution of it.
You want to hold it? Okay. This is teamwork, so I will continue. The second part is about the objective. We had a long, very long list of objectives, but we're able like to come up with the 3 main objectives. The first one is to enhance the skills and performance of healthcare workers at the service delivery level. And the second one was like to foster a culture that will enable an environment for continuous learning. And then the third one was to help to set up a system for increased staff motivation. As you said, we believe the more the staff will be motivated, the better they will do their job, and the less error we will have. Under that, we had also like a set of activities. We had just the time to list those activities, maybe not to organize them, each one of them under the respective objective. So the first one, I think, was to conduct a gap assessment for the healthcare workers, managers, and trainers, and also to capacitate the institutions to create a continuous learning system, and then to develop tools that will enable the trainees and the managers to foster this system for continuous learning. And then we had we thought of setting up a system for a public recognition for the healthcare workers. We also thought of like a system where we have like the peer experience sharing among the trainees. And then also feedback. We said feedback are very important. In terms of sustainability, we thought that we have to document the lesson learned along the line, so that when we move from the pilot phase into the scale up, we have evidence. Thank you.
Bang on time, yeah. Any clarifying questions from our peer review panel? Michael. The question is, was the solution digital, paper, or a combination?
I think we said the one thing we excluded from our solution, it would be something that heavily depend on internet. Yeah. So anything, we are open to explore anything, but anything that solely depend or heavily depend on internet, we were not up for that.
One thing we recognized was that there really is a need to involve the implementers in the process, because half the time you're making solutions that they're not a part of, and therefore they don't see it as important. And we highlighted the point that we said this morning that people can go to a course because maybe they get something, but the same person will actually, if they think something is important enough, they will actually dip in their own pocket to get that something, which means that maybe it's a perception of what you're giving them. And we thought that it was very important to have buy-in and to engage properly, not only the people you're training, but also the people who supervise them, and to strengthen that system of supervision at that level of implementation. Because the integrated supervision from the center going to the health facilities, for most of us, just doesn't work for any number of reasons. No fuel, not enough people, no blah, blah, and it goes on. But if you could capacitate the people at that implementation level to be able to follow through and to make sure that what people have learned is actually implemented, I think that would help a lot in getting transferring skills and knowledge to the actual workplace, and I think would be kind of motivating for the institution, because then the culture is kind of inculcated where they know we went for training or we've been trained on site, however you've trained them, this is for a specific purpose to accomplish specific goals, and we are accountable. And we even highlighted that even the government should make sure that those people are accountable because we've put resources in there, effort has been made, and therefore the systems of accountability, the strengthening those systems of accountability at that level is very important.
We'll move now to our orange team, which is incentivizing learning. Oh, sorry, a round of applause, please. Yes, thank you.
So in our group, we were looking at incentivizing learning. How can we change the context of training and incentives to better promote learning and demonstration of knowledge? Now, the main problem here is that attendance at public health trainings has become systematically monetized, leading to very expensive, non-sustainable training approaches, which show no results except the number of people trained. We estimate that every year over $100 million goes into immunization trainings. And the key results we have to show, number of people trained. The goal here is to transform health systems to move from incentivizing attendance at trainings to incentivizing learning and performance via more intrinsic motivation factors where the healthcare workers are learning because they love to learn as opposed to learning because of the external motivation factors such as money or per diems. And we have three main objectives. Sorry, the notes, we're working on the notes. So we have three main objectives. One is to promote a learning culture so that healthcare workers see learning as a process rather than as an event. Our second key objective is to implement learning incentives which are integrated with government accountability systems, i.e. rewards and sanctions, learning incentives, yes. And the third is to implement performance support processes. We haven't quite gotten to the fine detail of the activity, but we have broad strategies or approaches which we want to consider. And we have looked at this along the lines of responsibilities for government, for donors, and for partners. We established already that a lot of the resources that I described earlier comes from donors, comes from partners. Now, so we have roles and responsibilities for each person to achieve the desired objectives. For government, we're looking at government implementing learning incentives as continuous education credits, which tie back to government reward systems, e.g. certificates that can contribute to future promotions. So the thing is, if you decide to incentivize learning by providing certificates, say certificates of attendance, but what if the certificates of attendance don't count? So I attend a training, I have a certificate, I keep it on file, it's beautiful, it's colorful, but then what next? When it's time for me to go through a performance review, does my supervisor care about the training I attended? Does the fact that I have gained this new knowledge, is it going to contribute to anything in my career? Take, for example, a lot of us sitting in the room here have paid so much money to acquire our education. Some of us are still going through more and more courses. Why are we doing this? We're doing this because we think that the new knowledge we're gaining, the new learnings will in some way contribute to improving our career. So if healthcare workers know, if there's an assurance, if government goes an extra step to take on these incentives, these non-monetary incentives, and ties them back to government reward systems, it can encourage healthcare workers better to learn. Another thing, responsibility for government to consider, and an approach for government to consider is to provide mandatory and optional learning options for healthcare workers. And another thing we looked at government doing is coordinate partners' efforts at incentivizing learning and implement more on the job performance support rather than off-site trainings. One of the things we discussed is this: why do you need to give money to healthcare workers to attend a training? A lot of the time, it is because you moved them away from their hospital. If they were in their hospital and you brought the training to them, say it was on the job training, mentoring, performance support, you likely spend less depending on the model you adopt. So implementing more on the job performance support as opposed to off-site trainings that require huge monetary incentives. What do donors need to do to get us from where we are right now, where we are paying participants to be trained to where we want to go, which is where healthcare workers are learning because they think it adds value to them, it adds value to their work. We think that donors need to change the way they are funding trainings. So if you give us money to pay participants when they come to trainings, we don't want to underspend on our budget, so we will definitely pay the participants. And donors can change the way training funds flow during grant making. I provide funds only for acceptable reimbursable expenditure. We acknowledge that there is expenditure that is unavoidable. For example, in our earlier learnings, we note that 10% on the right-hand side, where you still inevitably have to leave your health facility, your health post to come to learn outside your site. Definitely, you will be reimbursed your transport. Like we're here, we have to eat. We've not been fasting all day. And now we will reimburse unavoidable expenditure rather than per diems, if donors change the way funds flow. Another responsibility for donors is to avoid funding vertical training projects and consider more integrated, funding more integrated training approaches. Why is this? So what if immunization decides this is really great, we have learned so much from here, and we're going on to implement no more monetary incentives, and it's the same healthcare worker who is involved in immunization that is involved in, say, malaria and HIV. And so you stop to provide a monetary incentive for immunization and the other people are still doing it. So naturally, they lose interest in immunization learning and go to the one that is still kind of juicy and attractive. So we're looking at the government considering like a broader primary healthcare approach and looking at more integrated approaches. Partners' responsibility to support government to design, test, and implement non-monetary incentives, and remain committed to implementing non-monetary incentives for trainings. Thank you.
Very good.
So on behalf of my group, I greet every one of you. Ours was to discuss on creating structures that will support change. And the question is, how will institutionalization of government structures and or academic institutions will help to support new training methodologies for EPI. So we had a lot of brainstorming, and I must confess our work is still work in progress. But we've made some very important agreements as a group. And so we learned a lot from the various experiences that we had from the members. And one of the key things that we agreed upon is that we need to have a functional structure within the government that will help to drive this change that we want. However, also bearing in mind the experiences we had, in so many places the structures are there. So the question is it just the structure, or what are the important drivers that we need to identify, push forward to the group here that will help to really actualize that this important component of government? And so our solution is to establish functional working groups, both at national and subnational levels. However, in doing that and in addressing the concerns that were raised in the group, is that we identified 6 important drivers that we really need to walk through to ensure that they remain functional and sustainable. And one of the key things we mentioned is that government should be the driver, and within government we should have a responsible person with clear terms of reference that should be able to really lead this process. So that leadership component is very, very strong. And second important thing is that we need to really create that motivation for change. Why do we really want to have this kind of change? So, and it cut across both at the higher level as well as at the lower level. And we are talking about opportunities for continuous learning if we go through new methodologies. We're also talking about continuous professional career development, both at the national and subnational level. These are things that will really make people to really want to buy into this new change that we desire to have. Most importantly, we want to be sure that accountability is really put on the table so that people will really be happy to really partner and move this trend that we want to have for change towards innovations for training. And I'm happy some other groups have mentioned integration. we also strongly believe that when we push this agenda forward with evidence that integration will be the key thing that will really help to ensure that this functionality remains beyond just the pilot state, but on a sustainable basis. And we said it should be able to address primary healthcare components. So trainings should not just be what is happening in malaria, primary healthcare, MNCH, immunization should be all integrated so that there will be, we'd avoid duplication and unnecessary overlap. And we also mentioned that we discuss about the issue related to continuity. What if there is a change in government or leadership? So we said one critical component that we see is missing at the moment is for us to ensure that we are able to establish standards of really how these committees, in terms of systems and policies, that will help to really outlive whichever individual or system that we're in there. And then the last but not the least, we agreed that content should be standardized, but most importantly, we should also be having this common approach to measurement to be sure that different methodologies that we say we should allow people to really absorb so that we can be able to say at the end of the day that this is really the best fit for us within the context of which we are. So these are some of the things that drive us, but then we ask the question, why is this really important? We know that when we establish coalition of various stakeholders, okay, I forgot here to add that thinking beyond just the government institutions, the training institutions that are available there, we should be able to bring them as members of this technical training working group so that there is that synergy or a link between what the government is doing and what the, because they are the custodian, the core base of where we can get this technical expertise to be able to transform the government agenda in capacity building forward. But here we are talking about we need to improve on accountability and transparency is important. If everybody is on the table, you know how much is there, and then everybody knows clearly. It helps to optimize value for our investment, and it also helps us to really improve on our sustainability. And this coalition will really help us to springboard these change agents that we really need, because it's not just a bilateral discussion between government and one partner. Other partners are there, and then they will help us to really move forward. The next thing we ask is, what are we trying to solve? So we are trying to solve this high failure rate of our current training efforts. We want to, the structures are not conducive to change and innovation. And what change will the project do? It will improve on the quality as well as innovations within the training. And our high level goal is to institutionalize innovative and effective training to achieve responsive and resilient health workforce. And the impact is that it will contribute to the overall health outcomes through service delivery that is qualitative, and it will also give an indirect impact where it will contribute to the reduction of mortalities and mobilities. And then how the project is building on science, learning science. We said evidence-based will be our justification. Whatever that we put on the table, we need to use science to really push forward. And most importantly, it will help us to address this flexibility that will accommodate new approaches to training that are really evidence-based. Thank you.
Thank you. So next we have our dark greens, who are looking at training in fragile states.
Hello everyone, can you hear me clearly? So unlike every other group, we don't have our flip charts as we are a fragile state. So you would see me flipping through both my computer and, where possible, our notes on the sheet. So our topic was to look at training in fragile states. And the concept we worked out on was very simple. We were going to design and implement a healthcare worker training on the basic or minimum standards for immunization service delivery through blended learning. You know, the background of fragile states, and we talked a lot about what's happening in the northeast of Nigeria, Borno State specifically. There was some reference to Somalia, to Sudan. And what we saw, the picture there basically, is that there are significantly low levels of immunization service delivery on account of the insurgency, high levels of internal displacement, including healthcare workers' displacements, and the need often to the need to recruit on very short notice formally trained healthcare workers who have little or no experience to support program needs on very short notice. We talked about these resulting in a lot of outbreaks of preventable diseases, and of course, within the background of the fact that there's ongoing introductions of new and more expensive vaccines. So the impact of wastage is a lot more astronomical than what happened, before. Now, our objectives are to ensure that we have at least one fully trained healthcare worker available at each service delivery point, and to ensure that each service delivery point is also equipped with performance support tools. And we looked at job aids, checklists to ensure that work is being done against those job aids, and where possible, instructional videos. On core areas, 4 core areas we agreed on was that every health worker should have knowledge on vaccine handling. Every health worker should have knowledge on injection administration and safety. Every health worker should have knowledge on how to provide outreach services and on waste management at a very barest minimum. We are assuming that to be able to achieve our project goals, that all other infrastructural requirements for service provision are available. I mean, the vaccines must be available for them to be properly handled. So assuming that they are available, we are assuming that we will have technical expertise for development of these training support tools we've referred to, that resources would be available, and this is obviously also a dependency for success, that the health workforce to be trained is available in the first instance, and that we have the political will for this project to go on. Key partners for successful execution: the government, community leaders, including traditional and religious leaders, development partners, and because it is a fragile state, we recognize that the security agencies also have to be involved. The activities we were looking at: conducting a needs assessment. There's been a lot of talk about an audit. So yes, a needs assessment. And we looked at the peculiarities of conducting needs assessments in fragile areas and the fact that sometimes inferences have to be made. Something as basic as you have 25 local government areas, maybe 5 are accessible, but you have health workers deployed. Now, you could estimate the level of competence of a health worker from the number of years or months or days within which they've worked in immunization, and that helps you know as a base case, this person is at a 0 level or at some level of knowledge, and from there start to extrapolate in developing your needs assessments. And of course, we talked about the development of the performance support tools themselves. This is where I move to paper. Also, we talked about a huge activity that needs to happen is advocacy and engagement of the government and the community on these changes we want to bring into the system. And of course, identification of the resources that are required for execution. We talked about the things we could integrate from the learning theories, and we were particularly impressed by prioritization of the subject matter using the 70-20-10 rule. That ranked pretty well with us. And the need to involve subject matter experts in development of any of the solutions that we are putting forward. In addressing things like language barriers, cultural issues, gender, religion, we also again talked about bringing the subject matter experts together, the traditional and religious leaders, the government, and all this group, this core group of people should be involved in the design, the development, and to some extent, the deployment of the training solution. And then there was reference to ease of localization as a concept. The learning tools, like I had said that we talked about, were paper-based job aids, checklists to vet these job aids, the utilization of these job aids, and videos, instructional videos for learning. For post-training follow-up, we looked at in-facility supervision. We keep referring to the fact that this is a fragile area. It is difficult for someone externally to have to come and conduct supportive supervision. So within the facility, that health worker has a supervisor who would be provided with a checklist of sorts and who on a bi-monthly basis or fortnightly basis would validate the work that healthcare worker has started to do as a consequence of training. So you're checking improvement over time. We're saying within a period of 6 weeks to 3 months, there should also be some external person who comes to validate or check the effectiveness of the training as well. And there was reference in the course of the needs assessment and implementation of this plan, there should be a pre-assessment, there should be a during learning assessment to see how there's been improvement, and of course the different levels of post-learning assessments on a quarterly basis. The frequency of assessments will obviously increase over time based on how performance has improved. Thank you.
Thank you. Any questions from the panel?
Just a clarification, were you thinking of routine immunization as opposed to campaigns?
Yes, we're thinking routine immunization because going back to the fragile states, campaigns are happening, but routine immunization is currently suffering.
And the second one was there an assumption that there would be a demand for, that there is a demand for immunization?
Yes, that's one of the assumptions.
Very good. We have our penultimate group, delivering existing training in new ways. Our light greens go next, incorporating up-to-date information in pre-service training.
Good afternoon. We had a lively discussion in our group with a lot of different experiences that folks brought to the table, including some interesting ideas, people that had who are pre-service faculty who had served as in-service trainers for immunization activities, and faculty who had brought students in to help with immunization activities. So a lot of really good ideas. In particular, two of our members presented a poster yesterday, which is still outside, from NESI, the Network for Education and Support for Immunization, out of the University of Antwerp, which is a collaboration with WHO, and I'm going to talk more about their programming. Pre-service curricula are very difficult to change. These are multi-year curricula with a lot of stakeholders involved. So we recognize from the get-go that this it's a difficult task to do. Many curricula that were surveyed by the NESI WHO project were found to be deficient in their immunization content. Either no content was defined or was inadequate. They also found that materials were lacking, practicum supervision was inadequate, faculty were not up to date in their knowledge, and there's a lack of harmony between pre-service and in-service training. Also, pre-service comes in different flavors and levels. You have nursing pre-service, which is often under the Ministry of Health, and physician pre-service, which is often under the Ministry of Education or Higher Education. And you might also have other mid-level cadres, such as physician assistants, clinical officers, those type of things. You also might have, especially in the medical sector, public schools and private medical schools. So our goal was to produce medical and nursing school graduates with knowledge and skills to deliver high-quality immunization services. The impacts, the direct impact would be quality immunization services provided in both public and private sector health facilities, and hopefully a reduced need for in-service training. The indirect impacts would be saving lives from vaccine preventable illnesses and saving dollars, money, in terms of reduced in-service training and reduced need for medical care. The objectives are to integrate WHO immunization content into national public nursing schools. We would try to do this starting in one country, all the nursing schools in one country, and those are deemed to be fairly centralized. And then we would also work with 2 medical schools, one public and one private, and with the possibility of expansion if this pilot project worked. And the second, in addition to integrating basic content, we would also provide regular updates to the schools so that the content would remain up to date. I think that's where you take it.
So that is a form of integration, or teamwork, as the previous speaker said. So the gaps in learning that we are planning to address is mainly for students that are new learners. We were in this field, so we want them to have the content integrated in more than one course. The content is new, so it should be integrated in more than one course. So the ideal content, we looked at the curriculum we currently we have updated recently, and we looked at what is inside, and we provided the information which is inside, that is around 19 hours of classroom, 10 hours of skill lab, and 4 weeks of clinical practicum. This is what is recommended, but now it needs to be adapted. And also there are exams and questions in the field placement. The technology that is to be used is, there is a variety of technology that is proposed. We have job aids, posters, DVDs or videos, and also practicum checklist and field placement for competencies, which can be facultative or can be also used when requested. The assumptions we had was we really need to have the willingness of the stakeholders to support this process. So we need to have the country that is really committed, and even the university at country level, and we need to have partners and the resources available, both the human, financial, and material resources. We need to have the partners that are in countries and even outside the country. We know most of them, WHO, UNICEF, and other partners, Ministry of Health, NGOs even working in the field of immunization. Training institutions also need to really be committed, and also professional associations. We have seen in many countries that they really have an important role that they are playing in this area. So we need to make sure that these associations are involved in these activities. So the activities we discussed in the group, the first one was to create a task force of stakeholders. This task force will have, this task force will have subgroups. We'll have a subgroup for nurses, so that the specificities of the nurses will be taken into account. And we'll have to conduct a kind of needs assessment to compare what is recommended in the curriculum and what is really need to be done, and try to update this curriculum according to what is really recommended, and also train the people from the faculty to make sure that they are up to date with the content of the curriculum, and that they are part of the trainings that are being organized when updates are being done. And finally, to provide the resources, provide regularly the resources when there are new development, like training material, equipment, job aids, and technology. There are two things I want to end before. I want to say before I end this. The issue was, how do you take into account the other programs when we are updating this curriculum? Because while we are updating the curriculum for immunization or other things, I know just two things. When we are updating this curriculum, the other programs are also updating the curriculum. How do we make sure that this process is conducted in a coordinated way? Because we will not go to make advocacy in the Ministry of Health while in a different, how do you call it, separately. We need to see how to coordinate these approaches so that we go together. That immunization is not doing what malaria is also doing. That is one thing. And the last thing was, how do we make sure that there is a regular update? When you have done this curricula, things are changing. How do we provide the update? These are the things we were trying to see, how to make sure, because the revision of the curricula are not happening all the time. Thank you.
Thank you. Thank you, Adrian. Any questions from the panel? In which case, we'll move to our last team, which is our pink team, delivering new vaccine introduction training.
So we don't have notes like most of the other groups, and we're delivering new vaccine introduction training. We did have a very lively discussion, and at the end of an hour, 40 minutes, we were all convinced that it was impossible to solve the problem. So I think I'm done here, right? No? Just joking. So on a more serious note, for the concept of our problem, we decided to focus both on in-service and also on pre-service training, because they kind of work hand in hand. You can't just do the in-service without doing the pre-service. The pre-service, they're eventually going to come out to the field, so it's important that you also engage with them. Then in terms of let's give me a second here. In terms of what the opportunities are, or what the problems we're trying to solve, some of them were pretty fun. We had a long list, but vaccine hesitancy is one of them. The country's prioritization, because countries have different priorities, so we have to work through that. Communication, healthcare workers, they have a way of communicating. We're trying to figure out ways to improve the way they communicate. And why this is really important to us. Now, when you think about it, it also gives you an idea to strengthen the healthcare system. Yes, sure, you're trying to introduce a new vaccine, but it's also an opportunity to do other things. So we thought we can use this platform for those purposes. For the project's goal, or the high-level goal, really, we wanted to be efficient use of funds and also develop a very effective training methodology, which we believe will contribute to the reduction of disease burden, mortality, morbidity, etc. The direct impact of our approach, where we saw as the community will benefit, the children, etc. And then the indirect benefits are strengthening the overall healthcare system. In terms of scale up, we thought that we would use both epidemiologic and demographic characteristics to determine how to scale up, because some areas of the country, or where the approach is being used, might have a higher burden of disease, so you probably might want to start there and then probably move down. And then in terms of the scaling up, you can also use sort of an evaluation approach to decide where to go, again, based on epi and also based on demographic factors. On the science aspect, using science or learning science to integrate in our project, we all agree that this should not be a sort of a one learning approach, one-off learning approach, as people forget. And so it has to be continuous, try to reinforce the concept. The gaps that we're thinking about for the project was forgetfulness. So sometimes in certain countries, you would have the training occurring and then the introduction actually being delayed for whatever reasons. And so what happens is that there's some forgetfulness. How do you sort of bridge that gap? Making sure that the healthcare worker knows exactly what to do when the actual introduction takes place. So that's one of the gaps we thought about. And also performance support. So after the training has been provided, what do you do then? So that's one of the things we thought about. And in terms of science innovations that might not, or that might impact the project, since we're thinking about the use of technology, some places do not have electricity, so what do you do about that? Some folks have a very low knowledge of use of electronic devices, network issues, etc. So we needed to think, we took this into consideration in designing our project. And moving on here, in terms of our primary objectives, again, we had a number, but the top three were involving professional associations. We believe that is key, including regulatory bodies and training institutions. So this is more a public-private sort of model. The national program themselves cannot do all of this, so we need to involve all of these agencies. It was also important that the peer, to introduce or include peer training or peer learning in this. So if you're able to train a healthcare worker at the lowest level, they should be able to train other people who work with them. So sort of working this into the actual training methodology. And also innovative approaches. So we decided that if the TOT approach was something we're thinking about using, yes, we don't use it the way it is, but maybe adding an element of supportive supervision in there, just try to think outside of the box. So the important activities that we thought about were materials needed to be developed based on the context of the problem, because a lot of the times you would find a manual which doesn't necessarily go to the root of the problem, it just covers general things, but it has to be very specific. their information is going to be based on sound science. And before we do anything, we're going to have an initial training needs assessment where we're able to find out what the specific issues are. So we'll take into consideration the cultural situation, cultural context, social, gender, etc., and then make sure that the trainings are targeted to specific areas that need a specific intervention. And so we divide this into a pre-training and a post-training. So this is the pre-training. The post-training would have the mentorship, supportive supervision, etc. And we'll have very clearly defined standard operating procedures. In terms of what the follow-up is going to be like, again, the supportive supervision is key, peer-to-peer mentorship is key, the development of job aids, etc., and also a comprehensive monitoring and evaluation sort of component where, there's a tracking database where we can sort of follow up people based on training and decide who's performing well, who isn't performing well, maybe using folks who are performing well to conduct additional trainings. That's a peer-to-peer. So thank you.
Thank you. Any questions?
So as you know, many countries are using the vaccine introduction grant, they get vaccine introduction grants, and then part of that is, big part of that is training. So in your group, was there any discussion on the way countries currently use the vaccine introduction grant for training, doing something different, because there is an opportunity to sort of change the way training is?
Thank you. We ran out of time before we got to that one. But I think we all agree that there are a lot of things that we fail to consider because of the limitations in time. But we did briefly touch on that, but we did not include it fully in our discussions. Thank you.